Marty van Tongeren. I think I probably know most of you on the call so far, but I'm professor in occupational environmental health at the University of Manchester, and I lead a project that was funded under the MRC NIHR Rapid Response call for studies into COVID-19 back in March. March or April it was funded, and we aim to focus our investigations on the delivery drivers, the sectors of deliveries at home, and the reason for that is that we, quite early on, and actually from when the pandemic started in China, it was quite clear that the public, well, the response to try to control the pandemic required people to stay at home and isolate, and that in turn required that a lot of the purchases that people were doing had to be online and had to be delivered at home. So it created a huge increase in the home delivery kind of sector. And speaking to the sector, they've been working since February, March at the level of Christmas, the normal Christmas levels. So it was a quite an incredible response to the crisis that basically was necessary to control the pandemic. And we wanted to kind of study this in terms of, what in what sense did this response kind of help the flattening of the curve of the epidemic, but we also wanted to kind of see under what conditions the delivery sector may be able to cause a kind of transmission risk under certain conditions, and we've done a lot of work since that time, speaking to a number of companies and understanding their response and understanding the control measures, and we're currently modeling that to basically go through a number of different scenarios in terms of infection risk. Now, clearly, one of the responses that is currently starting to gain momentum is the use of staff testing in terms of identifying early the employees that are infected and need to be isolating. And this is an important kind of tool, I think, in terms of controlling the epidemic. And I'm delighted that we have that David Denning, Professor David Denning, who's a co-I in the project on the delivery drivers, that he's agreed to give a seminar around staff testing, and particularly in the delivery sector. And that, for those of you who don't know David Denning, David is a professor in infectious disease and global health. Prior to February this year, it was mainly fungal infections, but I think like a lot of people since February have moved kind of rapidly also into viral infections. So David, I'll stop talking now and hand over to you.
Great, thank you very much, Marty. So what I'm going to do today is to share quite a few slides and just take you through various aspects of the virus and staff testing, and try and explain the rationale for different elements of it. And also, I've got a section on transmission, which I think is directly relevant to many of you in this sector. My sort of agenda today is to talk a little bit about the viruses, talk about infectiousness. I want to summarize something about the disease and how we treat it and the problems with what's called long COVID. I want to articulate something about antibody responses and protection from second infections, which is relevant, the transmission, and then there's some update on the vaccines, which we've all heard about in the news, but I've actually got some of the data to show you rather than just the press releases. So these coronaviruses are pretty small. They're about 1/10 of a micron in diameter. That compares with the filter size for masks, which is usually much lower than that. So that's why the masks are helpful in terms of filtering it. But they're much smaller than bacteria. And these are 2 diesel particles which we breathe in our lungs. And here's a red blood cell for comparison. So that's the sort of size of organism that we're dealing with. And these coronaviruses have been with us a very, very long time. This is what they look like under the electron microscope. They typically originate in birds or bats, and there are different varieties of them which can get transmitted to different animal groups. There's several that even fish can get infected, as you can see here, cats and dogs and so on. And this group here from camels and bats appears to be the ones that have caused the problems with SARS and now SARS-CoV-2 and MERS, and they're in lineages what are called B and C. And when you map these viruses about how common they are compared with others, there are a lot of coronaviruses that cause the common cold in this 1B group and the 2A group. The MERS virus, which still circulates in Saudi Arabia and is linked to exposure to camels and is much more lethal than our current epidemic, with about a 40% mortality. That's in a 2C group. And then the SARS virus, which came in 2003 or so, and the more recent SARS-CoV-2 are in this group here. And this is just a representation of what was called the Wuhan derived virus, although I think it probably came from outside Wuhan earlier than that. And this virus has changed in the space of this own epidemic, this very complicated diagram here, but there's a single amino acid change in the which is caused by a single RNA base change from a D to a G here. And what that's meant is prior to March, you had mostly this G614 virus, and now we have much more of the G614. And this is a more infectious virus, but the severity of disease is about the same. And that's one of the features of these coronaviruses, that they do change and they can mutate, and they can mutate in a given individual. So there is a shifting and a monitoring of the virus itself across the world. So just to help you with the terminology here, so it's a SARS-CoV-2 virus, that's the name of the virus. COVID-19 is what you have if you get sick from this virus. But we have a lot of asymptomatic cases as well, and we don't refer to them as having COVID-19 because they're not ill. They have a SARS-CoV-2 infection. So it's a terminology issue, but sometimes people do confuse the COVID-19, which is the disease from the virus. So let me just tell you a little bit about this illness and its infectiousness. So you acquire this virus from whatever source you do. There is an incubation period before you get ill, and that is typically about 5 days. And in the 2 days before you get ill, you're excreting virus. So we have 2 days of asymptomatic infection, and you can detect that with the swab test, which you can go and have a test for, but you can also do a viral culture, and you can do an antigen test. And so there are essentially 3 ways of detecting this live virus, and the most common of those is the swab, the PCR swab test. So the virus comes in through the nose or the lungs. As I say, the incubation period is typically 5.5 days, but it's as short as 2 days, and it can be as long as 13 days. And you get this large virus excretion for 2 days before the symptoms appear, and for another six days. And in normal people, there's no virus shed after day 8. So, and there was a very big study done in Taiwan early on in the epidemic, and there were no what's called secondary cases after day 6 after symptoms or day 8 after infection. And the only exception to that is people whose immune systems are compromised, for example, being having had a transplant or on steroid treatment or something else. They can excrete the virus for longer. And the other group that can excrete the virus for a little longer are the intensive care unit. The really, really sick patients can have the live virus for a little bit longer. But in normal people walking around at home, this virus disappears after 6 days after illness. And so that takes you to up here. So you've acquired the infection here, and the virus has effectively disappeared in terms of infectiousness there. But the virus is still detectable through the swab test, through the PCR test. And so some of the swab tests that are done persist, and they can persist for up to 6 weeks. Actually, you can have a detectable viral RNA test, but it doesn't mean that you have live virus. That disappears early. And the antigen test is a more accurate assay or test for live virus than viral RNA. And then you start to produce antibodies, and I'll talk about that. But during the period of your infectiousness, when you've got live virus, there usually are no antibodies present at all. So the incubation period, as I mentioned, is 2 to 13 days. There are 1 or 2 occasions it's been longer, but very few. And the commonest symptoms, as I'm sure you know, are fever, cough, and tiredness. Those are the 3 cardinal symptoms. But we also see patients with runny nose. It's quite common to have a loss of smell or taste. Some people have a sore throat. A bit of mild diarrhea or abdominal pain is common. Some people get quite profound backache or muscle aches and headaches. And then as the illness progresses, particularly if it gets to be severe, then patients can develop shortness of breath and chest tightness. And that's another common feature. And the other thing that's really distinctive about this virus compared, for example, with influenza or a common cold or lots of other viruses is various rashes which occur in patients. So this is an example of these, what are called these pseudo-chilblains, which are relatively common, 20% of patients. These little spots, which look a little bit like Coxsackie spots or herpes spots, but distributed in different places. That occurs in about 10%. These sort of itchy rash, which is more like an allergy, about 20%, and a maculopapular eruption, which is more like you get in measles, though they're not as dense as measles, in about half. And then a key occasion you get this really quite horrible livedo necrosis type of picture, which often means more severe disease. So these clinical, these skin features are really quite distinctive. But the complication that is a particular problem is pneumonia, and it's usually bilateral. And here you can see this is an abnormal area, this is abnormal, and so is this abnormal down here. And so this sort of patchy infiltrates, which what's called ground glass, is very typical. And this is an X-ray of a much more severe case. You can see the ECG lines up here, and both of these areas of lungs, the black areas with the ribs running across them, are much lighter than they should be. They should be much darker than that. And so there's quite extensive disease in this patient, less marked in this. And this is quite common. And patients, because of that, they get short of oxygen in the blood. It's called hypoxia, but they have a distinctive feature in COVID pneumonia of what's called silent hypoxia, because people don't feel particularly short of breath or upset. They will, as soon as they move around or try and eat or talk, if they've got extensive disease, they will be very breathless. But if they're just sitting still, they don't feel breathless. And that is misleading for the doctors and nurses looking after patients. And it's a reason why patients need to be very carefully monitored if they have pneumonia, because they can decompensate very quickly and become critically ill in the space of a few minutes if they've got really quite a profound hypoxia or low oxygen in the blood. And it's one of the reasons why early on in the illness it was a tricky disease to look after. So, as you know, one of the reasons that we have lockdowns and all the restrictions is so that we don't overwhelm our intensive care units in this country. And once you go into hospital, here's a typical example from, this was from China, but it would be true in this country too. 200 patients who come into hospital, and about a quarter of them end up in ICU. So you've got, if you're bad enough to get into hospital, then there's a chance that you'll become much iller, and that's a challenge. So this shouldn't frighten you from going to hospital if you have this illness, but that's just the reality of it. Now, we do have treatments, as I'll show, for these group of patients to reduce the ICU need, and they are actually reducing the ICU admission. But otherwise, there's around 25% of patients who need either non-invasive ventilation, which is a special masks with high flow oxygen, or they need actually to have a tube down and be artificially ventilated. And typically patients are in ICU for 2 to 4 weeks. So it takes some time to recover from this illness if you have a problem. And we've also, as is known for patients who are very, very short of oxygen, that lying on their front is also helpful in terms of better oxygenation for some patients. So the treatments that have come through, there's this antiviral remdesivir, which was actually developed by Gilead for Ebola illness, has a slight effect on reducing hospital stay and mortality in moderately severe patients, but not in the very severely ill patients. It doesn't impact on that group. So it has been used extensively. It's not a big effect. It's rather like the treatments we use for influenza. They have a small effect, but not a big one. Dexamethasone, which is a steroid, which was pioneered in part by the Oxford group, 6 milligrams, which is an intermediate dose given for 10 days, reduced death by 35% in those on a ventilator and 20% in those receiving oxygen, but it had didn't benefit patients with milder disease. So this is the opposite end of the spectrum from the remdesivir. There's a monoclonal blocking one of the inflammatory cytokines IL-6 called tocilizumab, and that slightly reduced mortality, but patients spent longer in hospital and got more infections. So this is not used as much. Beta interferon, which is one of the 3 main groups of interferon and is used for multiple sclerosis, was given, and that reduced mortality, but I don't think it's extensively used for reasons that are not clear to me. Regeneron have just had emergency approval in the FDA for their antibody cocktail, which does reduce the virus and decreases symptoms more quickly. Some people have been given blood or sera from people who've recovered from the virus, so-called convalescent serotherapy, and that seems to help some patients, but probably the earlier it's given, the better, and the data is not absolutely convincing on it. It is quite clear now that hydroxychloroquine, which was the medication that Donald Trump tried to encourage use of, doesn't work, and it can upset the heart's rhythm. So there's really no value in taking that. So one of the big questions is, why do some people get so much iller than others? What's the logic for this? And one of them is the viral variation. I mentioned one example, which doesn't seem to change on the example I gave you, the severity of the illness, but there's another mutation which reduces the severity. So it's less severe if you have that particular mutation. How much virus you inhale is probably very important. It's difficult to absolutely prove, because how do you measure how much virus somebody inhales? But it looks very likely that the more virus you inhale, the worse the infection. And that's a strong argument for wearing masks, washing your hands, and trying to reduce transmission, because you may not absolutely reduce transmission, but you minimize the severity of the illness in those who do get the infection. We know that being male, being older, having diabetes, and having blood pressure problems increases your risk of severe disease. And we also have some information, I'll show you just a little bit, of genetic variations from one person to another, which also affects how ill you get. So this rather remarkable piece of work, which doctors Zeeberg and Rabo did and published just very recently in Nature, found this very remarkable small piece of DNA that was strongly associated with severe COVID-19. It doubles the risk of severe COVID-19, which was going into intensive care or dying of the illness. And they compared 3,200 severe cases with 900,000 controls. And this DNA, it's a short segment, there's lots of little variations within it, and it's found in the Neanderthal genome. So that the closest link of this bit of abnormal DNA is actually to a Croatian Neanderthal. And we've got DNA sequence from about 5 Neanderthals, and this particular one, it's close. And the variation across the world of this piece of Neanderthal DNA is quite remarkable. So there's essentially none in Africa and very, very little in South America, but there's really quite a lot in Southeast Asia. So the highest rates, 30% have it in Southeast Asia, and in Bangladesh, it was 63% of people had 1 copy of the gene, and 13% of people had 2 copies of the gene. So that's a really high rate, and that may explain some of this apparent racial or ethnic variation in severity of disease. It's probably not the whole story, but it may be a part of the story. 8% in Europe, really quite rare in Northeast Asia. So up in Korea and Northern China and Japan, much, much less common. So this may be one of the several reasons why patients have more severe disease. And the last point to make about COVID-19 is the ongoing side effects from having the illness. So this was a study from Bristol, 110 people, and you can see that a large percentage here, 90%, had some ongoing symptoms if they had had severe disease, and about 60% if they had mild disease. So even mild disease gives you persistent symptoms. So you've got an abnormal chest x-rays, you've got your breathing, which is like asthma type or COPD type thing, is down. You get short of breath on exercise, and you have abnormal blood tests. So this is, and fatigue is a common feature of this illness, as you know, and some patients have thinking difficulties. There's a Parkinson's-like syndrome described as well. So there are a lot of long-term effects from this illness. So it is best not to have the illness, even if you're in a low-risk group. Okay, so what about infectiousness and protection? So you've seen this diagram already. This is the live virus diagram. This is your viral RNA in blue that comes and stays for really quite a long time. Here it's shown cutting off at about 3.5 weeks, but actually it can go on in some people up to about 6 weeks. And then you have 2 antibody responses. One's called an IgM, which is the quick early one, which then fades more quickly. And then you have a later one, which comes up called IgG. And this includes protective antibody. And so this antibody always comes up after the virus has gone away. So if you have detectable IgG, then you do not have live virus. And so this is relevant to staff testing, because if you were to put in program a repetitive antigen testing in patients to detect live virus, that's fine, and that may be helpful. But if actually patients have already got IgG, or not patients, people have got a detectable IgG, then they won't have live virus at the same time, because they're not compatible. And that's clear when you look at these tests. So this is an example of one of these lateral flow tests where both the IgG and the IgM are positive. And they looked in at this issue with respect to viral culture, and that means infectivity, and 90 positive samples. And if you had a very low amount of virus by PCR in that sample, you didn't grow the virus, and you never grew the virus after 8 days, although this PCR signal lasts for really quite a long time, as I've indicated. Now, there's quite a lot of variation between different people in their strength of antibody response. So here on the right-hand side, you've got strong antibody responses, both IgG and IgM. Here you have a weaker one, which is both of the lines are positive, but they're harder to see and they're not as strong. And here you have somebody who's just IgM positive. And if you were just IgM positive, then it is just conceivable that you have live virus detectable. You've got about 2-day crossover here. And so that patient, one would be cautious about because it could represent that infection before you get IgG. So if you look at that and you look at the antibody tests over time, these are patients who got sick, the symptomatic patients of COVID-19. These are SARS-CoV-2 infection without any symptoms. And almost all of them have detectable antibody. This is your IgE. But some patients don't produce antibody, and even late stage afterwards. And we know that none of these tests, and it doesn't matter how sensitive your test is, some patients do not produce antibody and are probably then not terribly well protected, at least by this infection. And when you look at the neutralization titer, and I'll talk a bit more about what that means in a minute, you can see that if you're asymptomatic, they have really quite good neutralization titers. And even some weeks later, you still have neutralization titers present. And this group of symptomatic patients also had pretty good neutralization titers. So if you look at this a neutralization titer over time, you can see you have this rapid rise. So this is 0 times 0. This is a month, and almost everybody has got a decent neutralization titer by the time you get to a month. And for most people, it stays up for 3 months or so without too much difficulty. Here's another a graph of showing the same sort of thing. You get some fade coming down, and 1 or 2 people with really quite low levels down here. But most people at 3 months still have detectable neutralization antibody. And that's relevant because it's relevant to the vaccines. So we use neutralization antibodies as a way of showing that patients have the vaccine is taken in somebody. It's been used for a very long time for influenza vaccine. We also know it works for RSV virus, and it works for many other viruses as well. So this neutralization antibody is a proxy for patients being protected from the virus. And there's alongside that, you may have heard of T cells, which is another part of the immune response. And here is a graph showing the relationship of T cell responses to anti-IgG antibody tests. And there's a strong relationship between these two things. So the neutralization antibody and the IgG antibody are, as I say, a proxy for the body's whole immune response. Okay, so what about transmission of this virus? As you, I'm sure, know, this is a virus that's spread through coughing, sneezing, spitting, singing, shouting, and in the hospital sector, aerosol generating procedures. And the virus can spread for some time, but actually it's this whole airborne spread issue was not known at the beginning of this illness. And our 2-meter distance is based, you can see the Ebola data where 3 feet was not good enough, but 6 feet was. Measles virus, in fact, just 2 meters isn't adequate. And this is probably true for chickenpox virus as well, is that greater distances are an issue. And you also will have heard of the R value, which is the reproduction rate, if you like, of the virus going through the population. So if you are infectious and you give the infection to 2 people, 3 weeks later, 16 other people are infected. So that's an R value of 2. And that's why you can get this rapid rises in the amount of virus traveling through society. But in fact, most of the transmission is hand, face, and transfer of the virus from your hands into the eyes, nostrils, and mouth. And most of us touch our face many times a day. And hand washing is really the most important part of trying to reduce transmission. Wearing gloves is also effective. Soap and water kills this virus as well as strong disinfectants. So although we worry a lot about the aerosol, in fact, it's these factors which are very, very important. The virus can survive on surfaces for really quite some time, hours, or in one study up to 9 days. And you will have heard about the salmon transported from Norway to Beijing, where the virus led to an outbreak there. So in cold environments, including refrigeration, it can last for really quite a long time. And it can stick to metal, glass, wood, paper, PVC, Teflon, and so on. So mobile phones, keyboards, cash points, all of these are potential agents of transmission. And if you clean them, then of course you can get rid of the virus. But if you don't, or you touch them and then you touch your face, that will be how the virus can so easily be transmitted. So there's a couple of other pieces about transportation which are very interesting. So there was a very interesting retrospective look at how many cases got transmitted on high-speed trains in China. So they looked between December and March. So they had 2,300 people who had the virus traveling on the train and 72,000 contacts. And when you look at that, the attack rate over time was down here in the 0 to 2% rate, really quite low transmission rates. But the longer that you spent on the train with somebody who's infected, the more likely you were to catch the virus. You can see that up to 2 hours here, really quite low rates of transmission, but even at 8 hours, you only got to about 2% rate. And overall, the people adjacent to somebody who had the virus, it was about 3.5%. So that's rather against the virus being transmitted simply by breathing. Coughing, spitting, and shouting might do that. And then when you look at if you're adjacent to the seat, of all seats, adjacent seats, same row without the seats, 1 row apart, 2 rows apart, 3 rows apart, you can see that the highest rates here are adjacent seats, okay, down here. So this takes you up to about 10% rate if you're sitting next to somebody with the virus, and if you are on the train for 8 hours, then you get to 10%. But at 2 hours, you have about a 3 or 4% rate. But if you're 3 rows apart, then in contrast, your rate is, this highest point here is 0.6%. So it's much, much lower. So this is not a major risk factor. And this is probably because people are, in China, they were probably wearing masks, because they usually do there. And maybe they kept the train very clean. And so keeping environments clean is also important. And this is some data that was recently supplied to me through Boeing and one of my colleagues in the university. And in 2020, there have been 16 million global flights, 1.2 billion passengers. In the US, 3 million flights, 200 million passengers. And they looked at the rate of transmission of the SARS-CoV-1 virus years ago, typical influenza, H1N1, and SARS-CoV-2 here. And you can see that with SARS-CoV-2, you've got 1,200 infected people traveling, 19 secondary cases that they could identify. And the exposure duration on average was 7.3 hours. So it's really quite a low risk of traveling in an airplane with somebody else with this infection. It's not zero, clearly not zero, but it is actually really quite low. And it's quite a lot lower than it is with influenza, for example, which is quite a higher transmission, almost 10 times as high, the transmission there. And so the other thing that's been looked at is actual aerosols, so modeling of the viral aerosols, and this is relevant for dentistry and certain other procedures like bronchoscopy and endoscopy in the hospital sector. So what they did was to look at different air exchange rates, exchange rate over 1 hour, 3 hours, 1 exchange per hour, 3 exchanges per hour, 10 exchanges per hour, or 20 exchanges per hour. And this gives you a sense of that if you don't exchange the air very much, then you have a higher rate of transmission of the virus. And this is one of the piece of data that suggested that we should keep our windows open, which of course when it's cold and wet isn't so easy. So when you look at, and this is based on viral load from PCR, so they're not necessarily infectious viruses, and the modeling is based on microdroplets from normal breathing or coughing, okay? And it's the room size was 50 meters squared and a typical rate of breathing. And when you look at this is a little complex, but let me just walk you through it. So if you have regular breathing and you have not much virus in you, so you're not coughing, then and you have only one exchange an hour of your air, the risk of transmission is really very low. On the other hand, if you're a high emitter and you have only one exchange an hour, then you rise to 1200 in terms of the amount of virus in the air. But if you then take that same high transmitter and do a 20 air exchanges per hour, that comes down a great deal by about 20-fold or 12-fold. On the other hand, if you're a coughing person, low virus, again, not a very high risk here, and that's lower if you do an air change. But if you're a high emitter and you're coughing, then the risk is much, much higher, particularly if you don't exchange the air. And it goes down a lot if you have 20 air exchanges, but it's still very high. So it's this coughing rather than regular breathing, which is a part of creating more virus in the air and therefore on surfaces as well. So it's not just how much is in the air, but it's also how much will be on a surface and how much cleaning there would need to be done. So I want to just finish with a few comments about vaccines. This is in its own right a very large topic. There are a lot of vaccines. So there's 161 not in clinical trials, 23 in preclinical early trials, 16 in what's called extended safety trials, and I'll show you an example of one of those. Then 8 in large-scale trials, 3 are licensed, and 2 have been given to the public. In fact, I think in China they're giving some vaccines to the public, and in Russia they are as well. So most of these most of the vaccines are directed against what's called the spike protein on the surface of the virus. So this thing up here is called the spike protein, and that was the one that had this slight mutation that I showed you, which changes the dynamic of the virus transmission. And that seems to be important, but actually there's lots of other proteins in here which can also generate immune responses. So there's a hemagglutination dimer, membrane, envelope protein, nucleocapsid protein, and so on. So one of the possible limitations of a spike protein only virus is that it's not conferring immunity to all the other components of the virus. So this is one of the Chinese vaccines. They deliver it in another virus. So they put this the RNA copy of the SARS-CoV-2 into an adenovirus, and then they give that. And they gave this to 108 participants, 3 single doses. This again was the spike protein antigen, and some people had a reaction to it, but they did get specific antibodies measured. They had neutralizing antibodies measured, and those were probably consistent with protection from future infection. Because when you look at that, they compared a low day 28 low dose, middle dose, and high dose, and 50, and 75% of people had a 4-fold rise in neutralizing antibody to the spike protein, and that's probably going to be protective. You need to confirm the protection, of course, with a much larger study, but that looks like it's protective. So that's one vaccine, and you notice that 75% response rate. So this is the just published paper about the Oxford AstraZeneca vaccine, which we've heard quite a lot about in the newspaper. This was led by Andrew Pollard, and Sarah Gilbert's been in the news as well about this. And they did the trial in Brazil, South Africa, and the UK. Sorry, I've missed a slide there. Sorry. I want to show you that one. And this is got this in the wrong order. So this is the response of that vaccine. This is there was a mistake in the calculation of the dose in one of the trial centers. And so they had low dose in some patients, which is about 50% of what they intended. So this is low dose, standard dose, standard dose, standard dose. And you can see that the vaccine efficacy was 90% in this low dose, standard dose, and 60% in the standard dose group. And when you look at people aged 18 to 55 with a longer period of time between the doses, you can see that this 90% held up, but this 60% went to 65%. And when you had a shorter time between the doses, you had a slightly lower efficacy at 53%. So that was that's the bottom line on where that vaccine sits. Now, you're listening to me, but you could be listening today to the FDA advisory board meeting on the Pfizer-BioNTech vaccine. It's actually online as a public event now. And they gave vaccine twice, 21 days apart, and then they followed the patients, and they planned to follow them for up to 2 years. They did active surveillance here, and their results are looking at the 7 days post the second dose here. And they wanted to have at least 6,000 subjects in that, 500 in each country. And then they were looking at side effects at 1 month and more serious side effects at 6 months, and deaths and serious side effects at 2 years. So that was the study plan. And these are the top line data from them. So all participants, you can see that the numbers are pretty large here, and the overall efficacy rate was 95%, which is really very high. And there's not much difference between 16-year-old to 55 and older than 55. Marginal difference here, not statistically significant. What was different, which hasn't been in the news to my knowledge, is that the response in the Asian population was lower than in the American Indian, the Black, or the white population. And I don't know the answer to this. I'm not sure if anybody knows the answer yet. I don't have any idea whether this Neanderthal DNA is relevant. Asian is a very broad term here because it will include people from China and Korea, as well as people from Southeast Asia and India and so on. But that is something that is relevant, I think, in terms of thinking about this. And then the other thing is the side effects. So how many side effects did you get? And so this is where they ask the patients, did you have any side effects? And they're looking at injection site reaction. And you can see that about 75% of patients, or vaccine recipients, I should say, got a reaction, compared with around 10% with the placebo. And if you look at unsolicited, non-serious adverse events, there was about 27% versus 12%. So you're likely to get a sore arm from the Pfizer-BioNTech vaccine, but not much else. So what does this all say? So the first thing is that the live virus becomes negative early after infection in almost all patients, and so the PCR persists for longer, but you can know that, and this PCR is much longer than culture, and that's persistence of viral RNA, but not viable virus. The antibody production occurs, and you can have a positive antibody at the same time as a persistent viral PCR, but it's a marker, particularly IgG, for protection. The treatments that we now have for COVID-19 reduce the death in severe cases by around 30%, but that's only 30%, right? It isn't up at 90%, which is what we would like to see. So there's a lot of room for improvement in our treatments, but at least it's a step forward. Most transmission is via surfaces, but aerosols and healthcare are important. And then coughing, sneezing, shouting, singing in enclosed spaces are also a risk. So there was one outbreak early on where a choir was, multiple people in a choir got infected, for example, and that's what you would expect given this, what's happening. The vaccines are effective and pretty safe, certainly compared with the disease in particularly at-risk individuals, and a sore arm is not much to pay for protection, I think, from this virus. So with that, I will stop, and I'm happy to take any questions if anybody's got any questions, particularly about how one might approach the issue of staff testing and protecting the staff in a positive way.
Excellent. Thank you, David, for very comprehensive and informative kind of lecture on basically lots of aspects of the pandemic. I don't know whether anyone has any questions. There's a question in the chat. We have a quite small group almost, so if you want to ask it, unmute yourself and ask it yourself, then please do.
Sure. Thanks for the talk. It's really good. The question is, how can you reduce the risk of nosocomial infections, especially as we're approaching winter and hospitals are becoming busier and segregation of patients starting to become more difficult? And especially in A&E and
it's an excellent question, and it relates. There's multiple aspects to it. So obviously, when the vaccine's rolled out, that's one clear protection. But prior to that, cleanliness is very important. Wearing masks, particularly for all aerosols procedures, are very important. Screening patients and staff for infection and having staff members who are ill not coming to work is also very important, and that's outside the healthcare setting and the delivery driver area. That's a big deal. And cohorting patients in the hospital so that patients with COVID are in one location and everybody else is another. So almost a hospital within a hospital is another a very important part. And then rapidity of testing and results and getting the results back as fast as possible is also another important part of protection. So there are multiple aspects of this, and it is a challenge. And you know yourself, because we've seen the news, that actually there have been quite a lot of hospital transmissions, which have been bad news, I think, for everybody concerned.
So interesting follow-up there, David. How infectious are patients by the time they actually get to the hospital?
Well, they're probably, if they've been going for 3 or 4 days, they'll still be infectious at that stage. But once they've been ill for a week, they're probably not very infectious. But the very, very severely ill patients who have a lot of virus in their airways and end up in ICU can be infectious for a little bit longer than the sort of ordinary person out in the street, I think. But once patients have been in ICU for a week, they're probably not infectious at that stage as well. And then you can actually, one of the challenges we face is that they get secondary infections, and because people are worried about the virus, they're not doing the tests for the secondary infections, and so there's a knock-on effect there, which is a fear of infection, which is a problem.
Okay, Damien, did you have your hand up?
I did, yes. Thanks, David, for a very fascinating talk. Given how quickly the vaccines were produced, is there any data on their long-term protection ability?
No, not yet. I think we have to infer that you're going to have protection for certainly 3 or 4 months because of the data we've got from natural infection. And we just need to keep checking antibodies. I suspect that we should be monitoring patients who've had vaccines with antibody testing starting at sort of 3 to 4 months after the vaccine to check that they're still positive. That's what I think I would want to do. If I was in a very critical setting, that's what I would want to do. Because I think it's quite likely that some patients' antibodies will fade early and others will keep going for a long time. And you really want to know those who are at risk of catching the infection again, and probably re-immunize them actually, or give them a second or a different vaccine. That's, I think, what probably will be the strategy at that stage. I think there'll be some people who'll be protected for 2 years and 3 years. So I think it's going to be very variable, and I think the IgG antibody testing is going to be the simplest sort of functional way to do that.
It's a kind of follow-up question. There was, when you see some of the people, interviews on telly about, on the radio about the vaccines, I think I heard people say that, the vaccine is proven to protect against the disease, but there wasn't yet sufficient evidence to say that the vaccine prevents against infection risk.
Yes,
so meaning that people who are vaccinated could still be infectious. Is that what's your view on that?
Yes, I think it is possible that because you're only using a spike protein, you're not using all the other things. One of the protection against virus infections is another antibody I didn't mention called IgA, which lives on the surface of the nose and gut and lungs. And IgA prevents you getting respiratory virus infections. I don't know whether this is going to generate IgA. And I think it's an interesting point, which I think hopefully will come out of the later papers. Yeah. My suspicion is that it probably will reduce infectivity, but it may not be as complete as protection from disease. That's my concern. So you might have a sort of 80% protection from infectivity, whereas you've got a 90% protection from disease or something like that.
So it might affect this kind of this notion of herd immunity at some point.
Yep, it might. Yes,
but if it's 80%, then that's probably still okay, right?
Yes, yes, it will be, I think.
Yeah. And any other questions?
Can I ask one?
Of course you can.
So just if the delivery company actually engage with the staff testing, how often should they do that? Should they use it as a screening tool, or should they only test people who start feeling symptomatic or knowing that they exposed to someone who had COVID?
So there are different approaches to that. I think for people who've reported having had an illness, antibody testing would be the thing to do first, because if they're antibody positive, you don't need to do an antigen or a PCR test. If they're antibody negative, then some groups are suggesting twice weekly testing, and you can sort of do self-testing with the antigen tests now. It's a nasopharyngeal swab that comes in the pack, and you can actually do your own test. And if you trust your employees and to deliver the right answer, then that would be a good way forward, because the alternative is that you bring them up to a center to have a swab test done. But if they're infectious, then they might transmit the infection as part of the process, right? And so it's some ways better to keep them sequestered away. And yes, absolutely, if they are symptomatic, then doing a test is an important thing to do. I agree with that. And then there are NHS testing centres for that, which they could go, or to casualty if they're sick.
Okay, I have another question, if I may, David. You in your conclusions, you mentioned that you say that surfaces and contacts is I don't know what the exact term was, but the main or the major or a major kind of routes of infection. It seems to me that you know it's going round a little bit, right? So initially, you know, early in the pandemic, it was surfaces, hand washing. That was the main the main kind of cause. Then you know, then the aerosol scientist, you know, basically started making noises and said, well, hold on, you know, it's actually aerosols that's the main cause. And actually, since then, all the focus has been on kind of aerosols, or most of it, and almost we forgot the kind of like the surfaces kind of like issue in terms of the risk of infection. And to be honest, I don't. You may kind of put it in your conclusion, but I actually think we probably don't really know which one is the main one. But my question is, do you think we've gone too much initially to the surfaces and then subsequently to the aerosols, and we probably now need to come back to saying, well, both of these are kind of probably equally important? Or
I think that's right. The reality, of course, is that in order to get a surface contaminated, you have to have a little bit of an aerosol. Yeah. So I think there is an initial piece of coughing or breathing or spitting on something and then leaving virus around and it not being cleaned up. So in a sense, that's true. And we definitely know that aerosols in the hospital sectors can transmit the virus. So aerosols clearly can. But I think if you, and some people have a lot of coughing with this illness, and they cough and cough and cough and cough, and others just have high fever and they lose their sense of smell and so on, and they don't have a cough. So they probably are not very transmissible, those people. It's the ones who are coughing who are probably more. And, you know, there's this concept of this super spreader. And I suspect that there's probably two elements of that. One of them is, well, three probably. The first is that they're not that ill, so they're able to mix and go around and meet people. If they were super ill, they'd be in the hospital. Yeah. Secondly, they've got huge viral loads, and the viral load varies a lot. So, you know, children, for example, catch this virus and they don't even notice it. And some of them have incredible viral loads and some have very little viral load. So the super spreaders probably have a lot of viral load. And thirdly, they're coughing as well, so that they actively expel lots of virus all over the place into all those people. So that's where this sort of super spreader piece comes from. Okay. But I think if we had if it was primarily an aerosol transmitted infection, you'd expect those cases in the trains and planes to be much, much higher than they actually are. And so I think it's more to do with coughing a bit, touching stuff, using your nose and handkerchief, you know, coffee cups that are discarded and then picked up by somebody or whatever, shared. It's all of that, I think, that's the biggest thing. The masks are a sort of reminder that, you know, this is a problem. And if you've got a mask and you're coughing a lot, it's actually quite difficult, isn't it? How do you cough through a mask? So it's a sort of also a challenge to wear a mask and cough a lot. And so it's a sort of marker of that as well, I think. But it's very, you know, detecting virus in the environment and actually monitoring is actually quite a very difficult thing to do, and people haven't done that much because it's a really challenging thing to do physically. Yeah. So
interestingly, I was speaking to Alan Bennett earlier this week, or in the meeting with Alan Bennett, and he mentioned that they'd done some measurements in outbreaks workplaces, and he found quite a lot in the canteen and changing areas.
Yeah,
and that was on surfaces.
Yes.
So.
Yeah, I guess so.
Okay, I think, are there any other final questions?
But there's a question about in masks. I think the masks only make a marginal difference compared with washing of the hands and sequestering yourself away if you're unwell as well. So I think they have a small impact, definitely have an impact, but it's a smallish impact based on the literature that I've seen about it.
Okay. Any last final questions for David? If not, then David, thanks you very much for this session. I think it's recorded, right, Kim? So we might make this available with your permission to others.
Yeah, absolutely, that's fine. That's what it's for, is to disseminate the knowledge. So I'm absolutely happy for that. No problem.
And it was really very, very good, very informative, and I think you know, I think everyone here on the line kind of like was learned a lot from this talk.